Hello everyone. I think it's time for us to start with the next tobacco control talk. For those who joined the first tobacco control talk, this is a lecture series usually organized by the World Federation and Public Health Associations. And it consists of lectures and discussions where we always invite one world-leading tobacco control expert. We focus on one interesting topic, which is relevant for the global tobacco control community. And this time, it's the first time that we have a shared lecture together with the World Federation of Public Health Associations and the World Heart Federation. So I'm very happy to welcome also Haneen. So we together will be like the hosts. So we were preparing some questions. And yeah, I'm happy to hand over to you, Haneen.
Thank you, Florian, and I'm very happy to be co-chairing this panel with you. I would like to start by introducing our speaker, Dr. Fong. He's the founder and principal investigator of the ITC project, and he will be providing an overview during the coming hour of the ITC project and present the key findings of 15 years of tobacco control policy evaluation research done in 29 countries. Dr. Fong, if you can, start by telling a little bit about yourself and how did you get involved in this project?
Thank you so much, Haneen, and it's really wonderful to be able to talk to the WFPHA and the WHF audiences because our closeness, I mean, we've been very close with WHF over the years. So my story is that I started relatively late in my career. I had been doing 15, 20 years of work in other areas in social psychology, judgment and decision research, and also did an extensive set of studies trying to reduce risky sexual behavior among inner city kids in the US. I had not had an interest in tobacco control until my colleague, Roy Cameron at the University of Waterloo, told me one day, had lunch with me one day and said, you know, Canada is about to come out with these graphic warning labels on cigarette packs. And I said, oh, what do they look like? And he showed me, and I was completely shocked because there in front of me were these packs that were the embodiment of everything I had learned as a social psychologist about graphic, vivid warnings and fear appeals. And I said, this is amazing. Does anyone know anything about whether these are going to have an effect? And he said, well, we did a literature review, but there aren't any studies out there that have ever done this in real populations. And I said, oh, maybe I should do that. And so I started on a very extensive journey, recruiting some wonderful colleagues that I still have to this day to do the ITC project, which is an evaluation project across now 29 countries. So it was just a luck that my colleague happened to show me these graphic warning labels and said, gee, there needs to be research done on that. And I thought, oh, I might as well do something like that. So that's how I got started.
Okay. Yeah, and because you are like the founder and the principal investigator of this major project, can you tell us more about it, about which countries were involved, about the research, how it was done, and yeah.
Yeah, let me just share my screen, and then I can just go through and tell the audience about the ITC project. Can you now see it?
Yes.
Okay, great, terrific. And I'm supposed to give some disclosures here, and so here are my disclosures: no funding from tobacco companies or nicotine products or pharmaceuticals, et cetera, et cetera. To start off with, the ITC project is the Framework Convention on Tobacco Control, which is the first ever WHO treaty, and it now has 181 countries that are involved in it. And the FCTC is an evidence-based treaty. It says it in the foreword. And for our perspective, evaluating the policies is really critical to provide the evidence that will support stronger and swifter implementation of the treaty. Because as I'm going to show you, the treaty is great and laws are great, but unless they are implemented strongly, they can't have any effect. So the ITC project now has 29 countries throughout the world. We started in Canada, US, Australia, and the UK. But then we quickly, over the years, gathered and started collaborating with many other countries. And we had a focus on low and middle income countries because, of course, as we know, in the 21st century, unlike the 20th century, the global tobacco epidemic is going to be 80% of the deaths are projected to be in LMICs. So it's really important to provide the evidence of what policies work to help inform policy making and policy implementation in those countries. So let me just, a second here, I can't see my screen here, so I have to kind of like, oh yeah, let me do that. Yes, we created this in 2002 before there was an FCTC. And we now have 29 countries, and it covers over half of the world's population and over 2/3 of the world's tobacco users. We do cohort surveys, which are surveys that you go to respondents, mostly smokers, some non-smokers, some smokeless users in countries like India and Bangladesh. Increasingly, we're looking at e-cigarettes and now HTPs, heated tobacco products. But all of those people we try to get at the next wave because we're really interested in transitions of people over time. And those who know epidemiology know the power and importance of cohort surveys. So those are our 29 countries throughout the world. And we have a global project here. We have a whole bunch of teams all throughout the world. We also have very strong relationships with the Framework Convention Alliance. Of course, the umbrella organization of civil society for tobacco control. And the ITC project is not just the surveys on the left. We also do experimental studies. We do extensive testing of tobacco products, including e-cigarettes and heated tobacco products all over the world. And we also do a simulation modeling project where we take our results of our other studies and we feed them in to examine what are the potential consequences in the future of disease and of death. So anyway, that's the ITC project in a nutshell.
Mm-hmm. And Dr. Jack, what do we know about the implementation of the FCTC and the impact to date? And what did the findings from the ITC project give us on the effectiveness of the FCTC policies?
Yes. Well, as I said, the really important evidence for us is to try to understand the impact of policies when they are implemented, and then feed that back in to other countries downstream that are considering such policies but haven't implemented them yet. So I was fortunate enough to be a part of the FCTC Impact Assessment Expert Group, which was formed in 2016 and was designed to examine what was the impact of the FCTC, the treaty, over its first 10 years, from 2005 when it came into force until 2015. And so we did a considerable amount of work for over a year in trying to assess what has the FCTC done. So we did a global evidence review. Our ITC project was responsible for that. We did country missions to 12 FCTC parties. You can see there, and you can see Pekka Puska, who was a former president of WHF there. He was the chair of the Impact Assessment Expert Group. We had a bunch of other external reports, and we reported our findings in the next 2 years in 2018 at the next conference of the parties. We also published a special supplement in the Journal of Tobacco Control on our findings. So one really critically important thing to know about the FCTC is that we have evidence showing that the more the greater the implementation of the FCTC, the more it reduces smoking. There's a dose response effect. And so we published this in Lancet Public Health in 2017. And as you can see here on the x-axis is the number of key policies of the FCTC, which are also known as the WHO power policies: higher taxes, smoke-free laws, graphic warning labels, bans on advertising, promotion, and sponsorship, and support for cessation. How many of these 5 key policies did countries do? Well, we had data from 126 WHO countries, and on the x-axis is how many they implemented, each country implemented, over the first decade of the treaty. And then on the y-axis is what was the effect on smoking prevalence. You can see that there is a strong downward line, which means the more you do, the greater the reduction in prevalence. And it's really quite stunning. A 1.57 percentage point decrease in smoking rate for each policy, which is a 7% relative decrease across all countries. This is a phenomenal effect. If countries did 5 policies, on average, they would reduce their smoking rates by a relative 35%. So the FCTC does work if key policies are implemented at a strong level, but there's a problem, and you can see it from that curve, and it's this. Of the 55 countries in the first decade, they did 0 policies out of the 5. 45 countries, there was only 1 of those 5 policies implemented. 20 countries only did 2. And only 5 countries implemented 3 or more of the 5 policies. So you have a very poor rate of implementation of the FCTC. So the FCTC has provided the foundation for strong action toward the #1 preventable cause of death in the world. But it has not been implemented. So going through some of the articles, you can see this is 2018 data. Only 21% of the world's population had done comprehensive smoke-free laws by 2018. That's 15 years after the FCTC came into force. The ITC project has demonstrated over and over again across different countries that when countries implement comprehensive smoke-free laws, they end up almost eliminating secondhand smoke in key public venues. And this is for restaurants. And you can see in Ireland, before their law, and they were the first country to implement a comprehensive smoke-free law, smoking in restaurants went from 84% to 2%, and then at follow-up 1%. You can see the same trend in Scotland, France, Germany, successful but not nearly as successful, Netherlands, Mexico City, which had a stronger law than Mexico next to it, Mauritius, and then Korea. China has a partial law, and you can see that it isn't even close to the effects of eliminating secondhand smoke of those other countries of comprehensive smoke-free. And Beijing, which was the first city to go entirely smoke-free in China, you can see that it trends down significantly greater than the other cities that we studied, which are partial. You also can see from this, we published a number of years ago, that in the long run in France, it stays down. It doesn't come back up because people get used to it. It becomes part of the norm. So comprehensive smoke-free laws work better than partial, much, much better, and they last a long time. Now in China, we have been really trying to get the government to, a lot of people have been trying to get the government to do something about the 300 million people who smoke, and smoking in public places is blatantly high in workplaces, restaurants, and bars. And when you have no rules, the red bars, the smoking is even higher than when certain establishments or workplaces have complete bans, which are in the green. So you can see the difference even within China. And not only that, but there's oftentimes an argument that smokers will rebel, they will, the civil unrest and so on. We show no sign of that because look at the support for smoke-free workplaces and restaurants in China itself. These levels, there are differences in various cities that I won't go over, but look at the levels. These are smokers who say, yes, smoking should be banned in workplaces and in restaurants, these are extraordinarily high, 60% and higher, basically. These are than any country we've ever studied. So should be no resistance. It's not an excuse for China not to engage in comprehensive smoke-free laws. The smokers will support it. Same in Japan. The prevalence of smoking in workplaces is really high. Look at that in bars, 83%. And support is extreme. China, 81% in workplaces. These are smokers. 78, 65, sorry, smokers are in the red. So 48, 40, 21, and 42% across those. Those are really, really high. In Ireland, before their smoke-free law, it was something like 13 or 15%. So there's a lot of support in Japan among smokers themselves for smoke-free laws, entirely smoke-free laws. Now with warnings, there's more success here. Half of the world's population has now implemented or is scheduled to implement graphic warning labels. That's better. In 2012, Canada, here are Canadians' warnings here, which are an example of strong warnings here with we added blindness and we added bladder cancer. And when you add these two items on your warning labels, knowledge goes up. You can see bladder cancer before bladder cancer became, a warning label. The percentage of smokers who knew about smoking causes bladder cancer was 28%. It actually went up to over 40% after the warning labels went on. And blindness, you can see that it was about 13% before, and then afterwards, when it became put on the warning labels, it went up dramatically to over 35%. So when you add health harms to warning labels, the ITC project has demonstrated that you get significant increases in knowledge and awareness of those harms. But there's a flip side to that, because when you take knowledge harms off the warning labels, they go down. And this is something that we published a couple of years ago that was not known until our study, that countries need to balance off, it's not just gain. If you remove harms, their knowledge will go down. So that's an important consideration for countries that are trying to find the best fit for the kinds of harms that they put on warning labels. So moving now to price tax. Here, only 13% of the world's population in 2018 met the standard for strongest level of implementation. This is a real shame. As we know, cigarette taxes and tobacco taxes are a win-win. Not only is it the case that it reduces prevalence and it reduces consumption of cigarettes, but also because it's relatively inelastic, there is a significant gain in revenue while demand is going down. So you've got a win-win situation, and it's just such a shame that the countries have not really implemented this fully. So I'm not going to go through a whole bunch of ITC project data on taxes. We've published about 70 articles on economic analyses of our data, but I just wanted to call your attention to something besides level of tax, which is tax structure. And there are different kinds of tax structures. We know that specific is more efficient in reducing demand than ad valorem taxes. And Xisheng led a paper that we published a couple of years ago looking at our ITC countries and showing that when countries change from specific to ad valorem structure, the more inefficient, there was indeed an 11% increase in consumption. And when they changed from uniform to tiered structure, uniform means that it doesn't matter whether you're a premium cigarette or a brand or a regular brand or a discount brand, it's all taxed at the same rate. To a tiered structure where you actually tax the higher priced ones at a higher rate than the lower ones, which is inefficient. when countries changed, they saw a 34 to 65% increase in consumption. These are extraordinary, important. So it's not just level of tax; it's how the tax is structured in each country. So we've done a lot with this to try to go to policymakers to get them to understand this and to work with, ministries of finance and so on. And in 2015, President Kenyatta in Kenya was offered there was a proposal in Parliament to go back to the tiered tax. They had a uniform tax at that time. So what we did was we prepared a report on the negative consequences of returning to tiered tax structure, that if they went back to the tiered tax structure, they would get more tobacco use and lower revenues from tobacco taxes. So we sent this to key policymakers, including President Kenyatta, and a few months later, he rejected the proposal to return to tiered tax. In a follow-up to this, unfortunately, later, because the tobacco industry is relentless, they went back to a tiered tax structure. But at least our evidence was, is always there in Kenya for them to refer to. We've also done work in evaluating menthol cigarette bans. We know that the problems with menthol cigarettes, they anesthetize the throat, they make the smoke less harsh. It's important in a number of countries in trying to promote smoking among younger people and among women. And so there have been calls for banning menthols throughout the world. Brazil was the first country to pass regulations for that, but unfortunately with legal challenges, it wasn't implemented. Canada was the first country to implement a menthol cigarette ban, and we evaluated this menthol ban across 7 provinces, following up from Michael Chaitin's wonderful work in evaluating the menthol ban in the province of Ontario. And after the menthol ban, menthol smokers were more likely than non-menthol smokers to make a quit attempt. Daily menthol smokers were more likely than daily non-menthol smokers to actually quit. Menthol smokers who quit before the ban were more likely to stay quit after their favored cigarette before they quit was no longer there. A very few switched to e-cigarettes, and of those that switched to e-cigarettes, there was no preference for menthol e-cigarettes. So this is an extraordinarily, I think, important set of findings that should support bans on menthol in many other countries. The EU has already done this. There are other countries that are thinking about it. This is evidence from the ITC project showing that it works. We've also done a lot of work on plain packaging. Here we've did some early reports. Australia was the first country to implement plain packaging in 2012. This is a report we did with the British Heart Foundation and with Cancer Council Victoria, and King's College London. And that was in 2014. We have some new reports now, standardized packaging in England and in New Zealand. Those are 2 ITC countries, and we have pre-post data evaluation there. And coming very soon is a plain packaging for tobacco products in Canada, which we've also evaluated. So we know that plain packaging reduces appeal, and there are data from England and Canada, and the measure is, how much do you like the look of your pack? And this is the percentage of smokers not liking the look of the pack. So if plain packaging reduces appeal, the percentage of smokers not liking the look of the pack should go up. And we found that in England, compared to 3 control countries of Australia, Canada, and the US, after plain packaging, percentage of smokers not liking the look of the pack jumped tremendously from 16% to 53%. And in Canada, it went up significantly compared to Australia and the US, but not as much. We suspect one of the reasons why is that in Canada, the pack wasn't very attractive because there were 75% of the warnings that you saw that I presented earlier. So it was already pretty, unlikable. Whereas in Australia at the time, when they implemented plain packaging, uh, and then it went from 30% to 75% with a change in warning labels there. So Canada and England both have, it reduces appeal, but plain packaging had more of an effect in England, less of an effect in Canada. We've also done work showing that health warnings are more effective after plain packaging when there are new warning labels also introduced. We've also shown on the right side that smoker support goes way up for plain packaging after their implementation, same as we showed with smoke-free laws. And so those are some of the findings that we have done on the FCTC and strength of implementation.
Yeah, and in the beginning, you showed us a lot about the strong associations between the implementation of FCTC policies and smoking rates, and you showed us also differences of the policies in the different countries. What else has been learned about how well FCTC has been implemented globally? Can you tell us a bit more about this? Or
yeah, I think as I mentioned here, the implementation has been really poor, but the Gravely et al. Article I think is a really important starting point because it had demonstrated the real power and potential of the FCTC, and then our ITC results show that with smoke-free, if you go partial, you get some reduction, but you have to go total in order to do that. And then some of the other findings that we have, there's a lot of attention that needs to be paid to the strength of implementation, not simply that you did something, but that you did it strongly, because there are guidelines for each of the articles, the policies of the FCTC, that are, as the word says, guidelines for how to do it right. And that is really the critical thing, to implement the FCTC, but to do it as strongly as possible.
And because you were like managing a major project in 29 different countries, you said like 2/3 of world smokers were involved. Did you have the feeling or even some evidence or some examples that your project was influencing FCTC implementation or the opinion of governments and things like this?
Yes, well, let me go to that. I think what I'd like to talk about just before I get to that question, Florian, is to go over, and for the audience, which is WHF audience also, to go over some cardiovascular harms of tobacco use and secondhand smoke, and the knowledge that smokers all over the world, whether people recognize the cardiovascular harms. We know that there are far more smokers that die of heart disease from their smoking than die from lung cancer. But this is not widely known, even by a lot of health professionals. So we did work partnering with WHF and WHO on assessing, the level of knowledge about cardiovascular harms throughout the world. So we concluded that, despite the known harms of tobacco to cardiovascular health, this report found that there are large gaps in smokers' knowledge of the cardiovascular disease risk of tobacco use, and in many countries the knowledge gap is substantial. So just to, for ITC data, this is kind of a starting point. This is lung cancer. The percentage of smokers who do not know that smoking causes lung cancer. So you can see it's relatively low. So most people know it, but it's extraordinary that, for example, in Japan in 2020, 25% of smokers do not know or believe that smoking causes lung cancer. In some of the other countries, in France, it's 6%. In Greece, it's 4%. In the LMICs, and those are in red, Zambia, 21%. China, 20% of smokers in China, the last time we checked, did not know that smoking causes lung cancer. So this is really it's disturbing, although it's relatively low compared to heart disease in smokers. Look, all of those bars are substantially greater than in lung cancer. Japan, 1/3 of people, smokers, do not know that smoking causes heart disease in smokers. In China, 42%, not much better than 10 years ago. That's a quote from the report. About half of smokers do not know that smoking causes heart disease. Well, it's 42% after that report. And in India, more than 1/3 of smokers do not know smoking causes heart disease. That's the second red bar. It's 30% when we went back to them. So it's not getting much better since our 2012 report about increasing knowledge in about heart disease. Now, this is even worse. Look at how long those bars are. Smokers who do not know or believe that secondhand smoke causes lung cancer in non-smokers. So that's lung cancer, secondhand smoke and lung cancer here. Now look at heart attack. It's even worse. The bars are even longer. 62%, well, 56%, the second blue bar, 56% of smokers in the UK and the United States in 2020 do not know or believe that secondhand smoke causes heart attack in non-smokers. 56%. That is higher than any of the LMICs listed as the red bars, including China, 46%, Kenya, 37%, and so on. This is extraordinary, and this is this is a call to mobilize public health officials, public health associations, cardiologists to get out the word about this, because this is really extraordinary that there's complete lack of knowledge, nearly complete. I mean, I find this just amazing that this the harms of secondhand smoke on cardiovascular disease, both chronic and acute, are not known. And this is stroke. This is really strong as well. Look at China, 63%, Zambia, 54%. Even in high-income countries, it's very high. Japan, 36% do not know that smoking causes stroke. Even in the UK, last year, 22%. Canada, 14%. This is really quite extraordinary. And warning labels can help this. As I said before, when you put things on warning labels, people know it more. And this is Mauritius, Greece, and the Netherlands. When they put on something about stroke in their warning labels, knowledge went up. This is a good policy to get the conversation started about how to raise awareness. Now, this is what's going on over time across all ITC countries, across all time points. Now, obviously, this is ridiculous because you won't understand this, so I'm going to break this down for you over time. This is the percentage of smokers who do not know that smoking causes heart disease in smokers by country. So let's break this down. England, US, Canada, and Australia, it's really a high knowledge and quite stable from 2002 to 2020. But even within that stability there, you see that Canada and Australia have significantly higher knowledge than England and US. I mean, almost twice, twice as many smokers do not know that smoking causes heart disease in England than in Canada. So even among that, there's still room for improvement. But let's compare it to other countries. So for example, the EU countries, you can see that in general, it's about average, but there are some countries that are high and some that have taken quite a journey since we started the survey. So Hungary is the highest. 31% of smokers do not know that smoking causes heart disease in smokers. Germany, 21% now, but it used to be 4, 6, and 4% 10 years ago. What has happened? That's important. It's important for public health officials in Germany to understand that there is significant increase in lack of knowledge about smoking causes heart disease. That's an opportunity for education. Netherlands, 12%. It went up during the time when not much was done in tobacco control. Now it's down to 12%. That's a success of the Netherlands, as we know, stronger efforts toward tobacco control in recent years. Greece, 5%. That's the best of the European countries. So now let's go to Asia, South Asia and the Southeast Asian countries. This is China, 42%. It's gone down significantly, but still 42% do not know this. Korea, extraordinary. This is just last year. 34% of smokers do not know that smoking causes heart disease in smokers. So Korea, as we know, has done significant, advances in tobacco control. This is one where Korea could, confront the lack of knowledge of smoking and cardiovascular risks. Japan, 31% and getting worse over time. India, 30%. Thailand, 26% in a country that is really strong in tobacco control. Malaysia, 10%, which is doing quite well relatively. And then Bangladesh, of course, we know Bangladesh has increased their efforts at tobacco control in recent years. So that's a good sign. And finally, no, not finally, African countries, Zambia, 28%, Kenya, 21%. They're both high, much higher than in the 4 countries on the left. Mauritius, which has a strong history of strong NCD prevention and control, 15%. And finally, the PAHO countries, region of Americas, Mexico at 19%, US 13%, Uruguay 11%, Canada at 8%, Brazil at 7%. So in general, you can see that there is generally relatively stable, but disturbingly high. There's some countries that I pointed to that have had success stories, but there are others that have shown, really going backwards in knowledge. We've also, so that's what I wanted to talk about with respect to, content from the ITC project that our WHF and public health associations, these are opportunities for change and action.
Dr. Jeff, you've given examples from all over the world on how the lack of knowledge maybe, and this is a call for action, like you said, for all the organizations to work on bridging that knowledge gap about the harmful effects of secondhand smoking and so on. We have a question from one of the attendees from the Stroke Association Support Network in Ghana, also asking about how do African countries, and I come from Jordan and I can fully relate to the same situation, how there are, no strong policies in place to control the high influx of tobacco into the African countries, but also the products are very accessible to youth and children. They're either sold individually in individual sticks, or they are sold very cheap. The access to the younger generation, which is a youth bulge in that region, in our region as well. So what approach you think, what can be done to address these issues in Africa and the Middle East, and what approach must governments in those countries adopt to address the harmful effect of tobacco products, including those like shisha among the younger generation?
There are probably 10 hours of response that I could make to that. Let me just say that, let me just say that in Africa, where we've worked in Kenya, in Zambia and Mauritius, we see it everywhere. We understand the challenge of countries that have, not, sufficient capacity to go up against multinational tobacco companies. We know the influence that the tobacco industry has on governments, but we also know that the FCTC provides a framework for mobilizing within countries and also across countries and regions to fight together, to gain strength from other parties, to gain strength from the Secretariat, to gain strength from WHO toward the battle against tobacco. This is not an easy fight, obviously, but the FCTC provides a legal framework, and Ghana is one of the parties of the FCTC. that automatically confers the possibility of getting tobacco control on the agenda, given that Ghana and many, all African countries are parties to the, almost, I think practically all are parties to the FCTC. That's a starting point. There's so much more that needs to be done. I recognize the single sticks as opposed to the packs. We know that in Zambia, something like 3/4 of cigarettes are single stick users as opposed to pack buyers. We know the tremendous access. There's a lot that needs to be done. But civil society, I mean, Ghana has wonderful civil society in the African region, and mobilizing to make those kinds of collaborations is a starting point. And then seeking out technical assistance that's available from the Secretariat is a good start. But as far as the individual policies, it's just I have so much to say that I really can't even start with that. But I think structurally, the FCTC provides a framework, a legal binding framework for taking action.
Absolutely. Yeah.
Sorry, and the same thing holds true in the Middle Eastern countries and so on. There is more capacity than in Africa on average, but the political will and the influence to the the tobacco industry is considerable. The tobacco industry is almost like they don't want to show their force unless they need to. So if they don't need to do very much, they just want to stay in the shadows. Mm-hmm. If there's strong tobacco control, action, then they raise up. So, up until relatively recent, the tobacco industry didn't have to care much about tobacco control in Africa. But now they have to, because of the FCTC and because there's a strength that's building within Africa. In the Middle East, there is more capacity, there is really strong advocacy and so on for tobacco control, but the tobacco industry can match that in power. So it's not, they use uniform strategies, but the strength of those strategies is just enough so that they get their way. And that's what I think we're seeing that a lot in the Middle East, and looking across different regions, they are strong as they need to be to get their way.
Yeah, and thank you very much for this response. And may I just ask, do you have maybe some kind of real-life stories on how your project was influencing some specific policies in some specific countries? Do you have some stories you can share?
Yes, I do. I mean, we have probably about 40 or 50 stories like this, but I just wanted to mention just a few. In 2010, Canada was the first country to introduce graphic warning labels in 2000. So 10 years later, they were in the process of revising the warnings, and then they made an announcement saying, "Oh, we're not going to continue revising the warning labels." And we said, "Wait a second, that makes no sense." So I and several others testified at the House of Commons Health Committee on the government's decision, and here are ITC data showing what happens to the effectiveness of warnings if you don't revise them. Tremendous wear out effects. After all, you see these warning labels on the pack over and over again. They're not going to have the same effect. So we presented those ITC data there, and it's not just due to us, but in the mix of the advocacy that was going on and the media coverage of it, just 2-3 weeks afterwards, the health minister reversed the decision, and the revision of the warnings continued. And those are the warnings, as I showed you before, that are currently on the packs, and they're going to be revised again, unfortunately, 10 years later, next year sometime. So, and then ITC was, doing our work, and this is what happens when you revise the warnings, they bounce back up. So we had an opportunity, so it's kind of full cycle. We present ITC data showing the need for warnings to be revised, then they revise them, then we say, good job. It worked. So it's a kind of a recycling back and forth between policy and evidence. We've also played a role in the two trade treaty challenges that the industry has brought against certain countries. And one of them was in the bilateral investment treaty between Uruguay and Switzerland. And PMI said, among other things, you can't increase your warnings size. You're already at 50%. And then Uruguay says, no, we wanted to go beyond that. PMI says, there's no evidence that that works. They wanted to go from 50 to 80%. And they did that. And then PMI says, there's no evidence that increasing above 50% is more effective. Well, we have cohort surveys in many countries, including Uruguay, and we can demonstrate this. We published this article. Look what happens to all the indicators that we've used to measure effectiveness of warnings over many countries, all 29 countries. When size increased from 50 to 80%, all of those indicators went up. Enhancing the warning labels beyond 50%, the Article 11 guidelines, can lead to even higher levels of effectiveness. When these were presented at the trade treaty, PMI had no response to it because we demonstrated that their factual claim was incorrect, and they lost. So we've also done expert testimony. I and Frank Chalupka and Dave Hammond were experts from the ITC project looking to support Australia at the WTO, their challenge of plain packaging. And so Australia was successful as well. So those are just a few examples of ITC and policy impact.
And thank you, Dr. Jeff. This is really very helpful for a lot of countries. And what are the areas of tobacco control you think the ITC project, is currently focusing on, and where do you think it's headed? What's your next research element?
Yeah, Haneen, as we all know, alternative nicotine delivery products have entered in and made an extraordinary change in most countries and soon to be probably all countries in the world. And that tobacco control used to be really easy when there were mostly cigarettes, in a few countries, of course, with smokeless like India and Bangladesh, but mostly throughout the world, it was cigarettes. And so it was easy. Now with e-cigarettes, with heated tobacco products, with hybrids, with other sorts of things coming down the road, it's very difficult. So we recognized starting in 2012, 10 years ago, the need to start tracking, e-cigarettes. And so we published some of the first papers, I think, in 2014, based on 2013, 2012 data on e-cigarettes there. And now that, vaping products and now heated tobacco products are a part of our present and also our future, we need to understand the interplay between these products. Transitions, switching. Is there any evidence that that people might be switching away from cigarettes to something like vaping products? Is there, among kids, is there a relationship between using vaping products and starting to smoke? All those things need to be considered in the mix, because we need to understand these, and we need to understand these, doing research that's outside the industry. And so that's what the ITC project has done. We have a very large U.S. National Cancer Institute funded project currently here. There are 5 projects altogether in this package. Project 1 is our ITC cohort survey, where we've ramped up and now we're measuring all sorts of things, not just cigarettes and FCTC policies, but also adding vaping products, e-cigarettes, and also now HTPs, heated tobacco products. We have Project 2, which is examining, the nature of these products over time and doing some product testing. We have Dave Hammond's ITC youth survey in 3 countries here. We have an experimental study by Warren Bickel, which manipulates and experimentally varies different types of policies and different types of attributes of products there. And then we have David Levy that examines all of those, the results and models to examine the impact of policies and the simulations for the future. We know that heated tobacco products are here, especially in Japan and Korea, all kinds of incredible products. We also know that they've captured a fair percentage of the tobacco market at the same time as cigarette sales have decreased. And there's some analysis suggesting that the two are related to each other, but this is an ongoing kind of situation. It's not static, it's very dynamic. PMI has stated that it's putting a lot of investment into these new products, including IQOS and also their vaping products there. And we're matching that. We have a ITC cohort surveys in Japan and Korea to examine the relationship between cigarettes and these heated tobacco products, and also in Korea vaping, since vaping is not nicotine vaping is not legal in Japan. And so now, of course, IQOS is available at the US and can be marketed as a reduced exposure tobacco product. So it's important for us to get ITC and others to get industry independent evidence on these. We also are, of course, been affected by COVID like everyone else. And in the 4 countries, Canada, England, US, and Australia, we stopped the wave and we put in new COVID-19 questions there. And then we restarted that survey wave. So we're doing a lot of work now on smoking and vaping and beliefs about COVID and smoking and vaping, as well as the impact of smoking of COVID on smoking and vaping. And these are percentage of our users, our respondents, saying that COVID-19 is more severe if you're a smoker than if you're not a smoker. And then more severe if you're a vapor, but not versus being not vaping. So the solid bars are smoking. So the Australia, Canada, England, and US, that's pretty similar. In the 80% believe that smoking makes COVID-19 illness more severe. It's less and significantly different across different countries for vaping. And that kind of makes sense because all the health authorities have said something about smoking making COVID more severe, but no governmental authority has said, advocates have said this, no government authority has said that vaping makes COVID more severe. So it's not surprising that there is a difference like this. We're also examining whether or not COVID has changed smoking. So there have been a lot of different studies done on this, but ITC, I think, is the only research project that's going to have all of the whether COVID made quitting or decreasing or a quit attempt, and also whether there was no change, increase, or relapse. So we're doing a lot of this. We're finding that COVID has no net effect on self-reported smoking there, but actually, maybe that's actually a positive sign, because in many population level traumas, we see significant increases in smoking, like 9/11 in the US. So maybe not having any net effect is actually a relatively positive outcome relative to the stress that all of us are feeling, obviously including smokers and tobacco users, due to COVID. So we're not saying this is a bad thing. It might even be, good thing relative to what it could have been if COVID was not at all related to a respiratory ailment in the same way as smoking is. Anyway, so those are where we're going in the future and in the present.
Then just thank you very much for this really wonderful and very interesting presentation, and also for the huge task you are offering, not just for us, but also for so many countries and people out there. And is there maybe some closing remark or anything else you would like to share about your experience, maybe some lessons learned or recommendations for younger researchers who try to attempt a project like this as well? Or
I think that, thank you so much, Florian and Hanin. It's really wonderful to have this opportunity to talk to public health associations all over the world, as well as, cardiologists and other health heart health professionals, including researchers, via WHF. I mean, our association with WHF is very close to our, history and my heart, literally. um, in that this is something, the power of smoking, especially in secondhand smoke, to cause heart disease and more acute heart conditions is widely not known. Not even among health professionals. I mean, in our original report, we showed that health professionals don't even know this. So there is a tremendous opportunity for and need for heart health professionals, cardiologists and advocates in the heart, to really maintain and extend the importance of smoking, tobacco control in their own work. Cancer has a more smoking has a more specific relationship with lung cancer and other cancers, but more people die of from smoking, from heart disease and heart attacks than from lung cancer. So there's a tremendous, as we've shown with, with the knowledge and lack of awareness of harms, there's a real powerful opportunity and need for that to be ramped back up, because it's not really getting any better. And that is at the core of what governments need to do to be responsible to alert their citizens, their populations, of why tobacco control is so important. Tobacco use, especially smoking, is the #1 preventable cause of death and disease. And for the researchers out there, it's really important for us all to gather the evidence that will support stronger action, especially toward FCTC implementation. FCTC sets the foundation for powerful action that's not being taken now nearly as strongly as it needs to be. So the name of the game is all about implementation, strong implementation, and research can really promote and to feed into policy making to make that happen.
Yeah. Yeah, thank you very much. I can just say thank you a lot to you, and also to you, Hanin, also for the great collaboration. And yeah.
Thank you very much, Dr. Jeff and Florian, and for the attendees and their time.
It was a pleasure being with you, and thank you so much for all. And people can write to me. I'm easy to find, so would love to talk to the audience and anyone who's interested in the things that I've had a privilege to be able to present to you today. Thank you.
Thank you very much. Bye bye.
Thank you very much. Have a good day.
Bye.